Thanks for having me today. I appreciate it. Thanks for your time. If you have any questions, feel free to go ahead and interrupt me and ask questions. That way we can get them answered right away. My name is Dr. Bryan Skulpoonkitti. I've been in Texas my whole life. I grew up in Houston, moved to the Dallas area, did my undergrad here at UT Austin, got my medical degree from University of North Texas in Fort Worth, and spent 5 years in Lubbock, Texas, where there's nothing out there, doing an anesthesia residency and a pain fellowship. So I finally made it back after 9 years of schooling and training, so I'm glad to be back. I'm happy to be here to talk about peripheral neuropathy. You guys, how much do you guys know about peripheral neuropathy? Probably a lot, I think. Decent amount, done your research. I made this PowerPoint myself to go over stuff. It's not a generic PowerPoint that some of you guys may have seen. I just wanted to go over some basic stuff and a little bit more advanced stuff that some people may miss talking about. And that the things that you miss can be the smallest things that help the most. So let's see here. So my objectives for today are to know the definition of peripheral neuropathy, also the causes of peripheral neuropathy, and how do I diagnose it in clinic, and what labs and tests I like to order if appropriate, and also how to prevent peripheral neuropathy and how to slow down the progression or stop the progression of peripheral neuropathy, and also what treatment options are available currently, ranging from medication management to physical therapy to injections to spinal cord stimulators, all the basic stuff all the way up to the most latest and greatest. So the definition of peripheral neuropathy is, when they say peripheral, it's anything outside the spinal cord. That's what they call peripheral. Any kind of pathology or disease state that causes a defect in the nerve or the conduction of the nerve to the spinal cord and up to the brain that can cause numbness, tingling, pain, and also muscle atrophy just due to the disease state of the nerve itself. With the definition of peripheral neuropathy, we can go over the causes. There's multiple causes. One of the main things is, of course, we all know is diabetes. Diabetes causes it. That's due to the blood glucose levels attaching to the cells and causing nerve damage due to the vessels around the nerve. So it's kind of like cutting the blood supply to the nerve, which causes a disease state. Another cause is trauma itself. Some of you may have known people with below knee amputations. They have phantom limb pain, or just the nature of the surgery itself. The surgeon may have gone through a specific area in the muscle, the tissue, the bone, and damage to the nerve. And the nerves don't regenerate like our skin do when you get cut. They don't grow back normally. They grow back very slow over years, and there's no set pattern to which they grow back. And at the same time, they can produce pain. Repetitive stress, such as you've probably heard of carpal tunnel syndrome, cubital tunnel, tarsal tunnel syndrome. Carpal tunnel, of course, we're all getting these days, typing on the computer, playing on our phones. Cubital tunnel syndrome is where you feel like you hit the funny bone and it's your little two fingers that get numb or have pain. Tarsal tunnel is in your foot. Repetitive trauma, running, jumping, previous athletes. It runs behind the medial malleolus, that bump on the inside of your ankle, and it can send shooting pain down to the sole of your foot. So that would be from repetitive stress. Another cause would be disease states or disorders. As we already mentioned, diabetes. You can also have chronic renal failure. Diabetes does lead to chronic renal failure. It's probably due to the fact that you're not excreting all the toxins in your body. You can also have autoimmune diseases that attack the blood vessels or the nerves itself, leading to nerve damage. Medications. What's common in my clinic is I get patients who've been on hepatitis C antiviral treatment, which can cause a neuropathy also, or HIV antiviral treatments that cause neuropathy. Another big one is chemotherapy that causes peripheral neuropathy. So that's pretty common. Alcohol use, chronic alcohol use in the past may cause peripheral neuropathy due to it depletes your B vitamins, and for your nerves to thrive, they require those B vitamins. And it can be environmental. Sorry.
Don't want to interrupt at this point, but I think there's one you actually left off.
Okay.
Because of mine, hereditary.
Yeah, that's one too.
Mine's extremely hereditary.
Okay, yeah, it's good to get a good family history and see how it's passed down, whether it's skipped generations or is it in males or females. That does exist. Environmental is another one. I got a firefighter who, in and out of burning buildings, carbon monoxide, then inhalational agents can cause peripheral neuropathy. So my most common diagnosis in clinic I see is, of course, diabetes and medication-induced peripheral neuropathy. There's also what they call idiopathic neuropathy, which there's no known cause. They can't pinpoint, they can't say it's familial or medication-induced. It's just there for some reason. Of course, your repetitive stress, carpal tunnel, cubital tunnel, and tarsal tunnel. And you can also have complex regional pain syndrome, which is where you've had a trauma to a specific area of your body and the nerve itself was damaged, causing a lot of vasomotor symptoms, other symptoms associated.
What is cubital?
Cubital tunnel syndrome is where the ulnar nerve, where your funny bone goes through there. There's a little tendon above it, and when it gets tight, it can squeeze that nerve. And you typically get numbness and tingling in your ring finger and your pinky finger. And it usually doesn't come from the neck, it comes from the elbow and below. So any of those areas where the nerves pass through, if there's a tendon sheath over it where it gets irritated, it can cause a peripheral neuropathy also. So I have a few pictures here of where the carpal tunnel is, which you're probably familiar with. And there's a great picture of that cubital tunnel in the second picture there. And of course, there's tarsal tunnel, which I see less common, but there are treatment options for that. Some people go to the podiatrist, or some people come see me and we can treat it too. So how is peripheral neuropathy diagnosed? Well, first off, you have to get a good history on the patient. You actually have to ask very specific questions and mainly listen to the patient, see what medications were used, to see if any other family members have had the issue, what's their medical history, any prior surgeries or trauma, what kind of treatments the patient has responded to, what they haven't responded to, because those kind of tell, can rule out other causes. If you don't listen to the patient, well then you can't get a good history, and if you miss the most basic things, that could have you make a mistake on the treatment plan. How many of you have been to physicians where they don't listen to everything and they've missed certain things? You have to spend a good amount of time listening to your patient. That's very key in my practice. I like to ask a lot of questions, review their medical records, or at least gather their medical records from the neurologist, the family doctor, look at their kidney function, liver function, vitamin B levels, everything counts. So, you have to also do a good physical exam? How many of you have been to doctors where they don't even touch you or do a proper neurological exam? Because if you have burning down your leg or your arm, it may not be due to a peripheral neuropathy. It may be coming from your cervical spine, your lumbar spine, or even those areas where the nerve gets compressed through the tendons. So it's very important to do a good physical exam, a focused physical exam, and a general physical exam. Testing for temperature sensation, pinprick sensation, reflexes, and strength. After getting a good history and physical exam, then I'll determine which labs are appropriate. I don't like to order labs just to order them, because if you order the labs without justification, you waste the person's time and money. And what are you going to do with the results if you find something that's unexpected, that's not pertinent to your treatment plan? You kind of cause problems by ordering too many labs. So based off my history and physical exam, sometimes I'll order appropriate imaging for the neck and the lumbar spine if there's symptoms and physical exam findings that are consistent to justify ordering it. Sometimes you can order a nerve conduction test or EMG, which neurologists typically order. I don't order that as commonly because I do a lot of my diagnosing based off a good history and physical exam, and if it's not displayed on an MRI or X-ray, then I'll go to a nerve conduction test because sometimes things can't be explained by MRIs. Other stuff that can order are vitamin B levels, as we discussed. Vitamin B levels can be depleted, leading to a peripheral neuropathy. Sometimes that's not reversible once you get that. Rarely, I've never ordered a nerve and skin biopsy test. Have any of you guys had a nerve or skin biopsy test for peripheral neuropathy? I don't think that's very common. I would imagine a neurologist may order that as a last resort. And of course, blood glucose, that typically the primary care provider's already ordered that for me, and that's pretty helpful to have. So after doing a good history and physical exam and ordering appropriate labs, we come to a diagnosis. But I want to focus now on the prevention of peripheral neuropathy or slowing the progression. So for repetitive stress, you have to pinpoint what's causing that pain. Or it can be as simple as your workstation. A lot of us use computers now. One simple thing I like to have my patients, you just Google on the internet, is an ergonomic workstation. I have a picture of an ergonomic workstation where they have recommended heights and viewing angle, not only to help with carpal tunnel, but help with pain all over your neck, your lower back. I think it's pretty helpful. This is something you can look up at home if you're on the computer a lot, and I think it'll be beneficial with that. A common question I get is an A1C. Do you guys have any question about what the purpose of an A1C is or how it works? Well, an A1C basically tells me when there's glucose in the body, it binds to the hemoglobin. Hemoglobin carries oxygen in the blood. And hemoglobin is inside a red blood cell. A red blood cell's lifespan is approximately 90 days to 3 months. So this is an A1C gives you a snapshot over 3 months as opposed to doing a straight blood sugar test before lunch or after lunch. This is a kind of a picture over 3 months. It gives us a better idea of how well your blood glucose is controlled. The better your blood glucose is controlled, that helps either prevent or slow the progression of diabetic peripheral neuropathy. So that's why an A1C is pretty important. Typically, you want your A1C less than 7%. They've done studies to where there's better outcome for patients, decrease in morbidity, or better outcomes in surgical results too. Because when you have diabetes, you get impeded wound healing, all that bad stuff happens. Any questions about A1C and why we do it as opposed to just a regular blood glucose at the time? Okay. So with peripheral neuropathy, I typically like to start with the most conservative stuff, basic stuff that's most economical to the patient that has been proven to work, which not always works, but I escalate my treatment plan as things go on. Some of the most basic things include non-steroidal anti-inflammatories, such as ibuprofen, meloxicam, or naproxen. Of course, there's contraindications to that if you have stomach ulcers or chronic kidney disease, which people with diabetes tend to have, or you just have chronic kidney disease due to an autoimmune or hereditary issue. I typically add a neuropathic pain medication such as gabapentin or Lyrica. How many of you guys are on gabapentin or Lyrica? Okay. Or tried one or the other in which one doesn't work, and one works better than the other, or it's just not working at all. So with gabapentin, it was originally designed for seizures. Neurologists use it for seizures because it slows down the nerve conduction through the nerves to the brain. They did a lot of studies for it for pain because all the nerves send signals to the brain the same way. They did a lot of studies in spinal cord injury and nerve damage. The maximum dosage is 3,600 milligrams a day. The average dose to where people with spinal cord injuries got pain relief was 1,800 milligrams. I tend to get a lot of patients who said have tried gabapentin and they say it doesn't work. Typically, they haven't even gotten to a high enough dose to say they failed gabapentin. I like to titrate my patients up over 9 days to a few weeks, as long as they're not having excessive sedation or swelling in their hands and feet, until at least 1,800 to say that they failed gabapentin.
I just wanted to say that the neurologist I went to after he diagnosed my neuropathic pain, which is in my feet, offered me a choice between Lyrica and gabapentin. I chose gabapentin because I knew it had been generic for a long time. Lyrica was still branded, and so I knew that gabapentin would be a lot cheaper, which it is. And it happened to work for me at a dose of 300 milligrams, except that it has a fairly short half-life, so I have to take it every 3 to 4 hours, or depending on, you know, as needed for the pain coming back. But I have to take it several times a day to maintain control of the pain that I have, but it works for me. And as the lady over there mentioned, my mom, it turns out, also has the same thing, and I suggested that she ask her physician for gabapentin, and she gets relief at 100 milligrams at a time. So 300 milligrams was too much for her, 100 milligrams. But again, she basically takes it before bedtime, and I don't know if she takes it at all during the day, but that's her. You know, but gabapentin works for me, and I'm really glad, you know, the first thing that my neurologist prescribed for me worked. That doesn't happen for a lot of people.
Yeah, gabapentin is like my go-to drug because one, it's generic, it's affordable. Lyrica can get kind of pricey unless
Very few side effects.
Yeah, if you don't have a coupon for it or you don't have insurance for it. But one of the most common side effects is sedation. It gets you sleepy, but that can help at night if you're not getting a good night's rest. One thing I recommend to my patients, if it's causing too much sedation during the day, well, you can take it all at night, which is safe too. Now, if you're waking up too groggy in the morning because all the gabapentin at night, I recommend taking it a little bit earlier in the night, timing it to where it kind of wears off, because the goal is to keep you functional during the day while still having pain control.
We just got a prescription today for gabapentin in the cream form to topically, and it's not supposed to have the sleepiness effect as much. So, would you just rub it, say, on your feet if you had neuropathy?
Yes, you can. I do prescribe topical compounds too, which work great. There's depending on what pharmacy you go to, there's different compounds there's gabapentin, there's lidocaine, prilocaine, ketoprofen. Those work pretty well, depending on what's compounded in there. And for some people, it just doesn't work, but it does get absorbed through the skin, but you can't really tell how much is actually getting absorbed through the skin, but they do work.
Maybe get through the daytime hours.
Yeah. The other drug is Lyrica. Lyrica is a little bit more expensive. A lot of people complain of excessive sedation or kind of loopiness. People get tolerant to that after about 3 to 4 weeks. So I get patients who've tried it and they stop taking it after a week. That just means you need to start at a lower dose over a longer period of time so you adapt to the medication. Lyrica, anything above 450 milligrams, I don't think there's much benefit to it. The maximum dosage is 600, and some people do respond to 600 milligrams a day. It works through the same mechanism as gabapentin. Other medications that you've probably heard of are antidepressants. Have you guys tried Cymbalta or nortriptyline or amitriptyline in the past? Those work pretty well. Typically for nerve pain, you use a smaller dose. Because we're not treating depression, we're trying to treat nerve pain. So it works for some people it doesn't work. That's one of those that I usually try after gabapentin or Lyrica hasn't worked. They do help you get nortriptyline. Amitriptyline will help you get sleep at night for some people. Nortriptyline has less side effects, less anticholinergic effects, such as dry mouth. So I typically try to start with nortriptyline first. And of course, as you asked, the topical pain creams. Yeah, I've prescribed lidocaine 5%, which is pretty concentrated. It works pretty well. The nice thing about that is it can numb up the area that's causing pain, but you can also put it on your joints if you have arthritis too. The diclofenac gel is an anti-inflammatory, which some people get results from, some people don't. And of course, a combination of stuff, compounding creams. And when all conservative treatment for medication has failed, sometimes people resort to opiates or narcotics. Those don't really target nerve pain specifically, but they work on mu receptors, which help decrease the sensation of pain. Some of the side effects of being on those medications for so long is, one, they cause osteoporosis. They promote osteoporosis. They also decrease your hormone levels. Females have testosterone too, so they decrease thyroid levels, testosterone levels, and estrogen levels, so they can affect how much energy you have. And you may experience some weight gain, so that's not always the best long-term option there.
What's the tolerance and habituation and problems with opiates
Yeah.
for long-term use?
You get tolerant, and sometimes when you're on it for so long, you develop opioid-induced hyperalgesia, where it can actually cause more pain because the receptors and the chemicals in your brain have changed over time. One area I do specialize in, other than medication management, is doing nerve blocks. Have you guys had injections done before in the past for peripheral neuropathy? Okay. So in injections, we target the nerve directly. That's the nice thing about it. And if the injections work, you might not have to be as reliant on the medications. Everybody responds differently to injections. We usually inject with a local anesthetic and a steroid. The steroid helps potentiate the length of time a local anesthetic will work, the numbing medicine, and also decreases any inflammation in the area. So that's what's nice and how it works. We do peripheral nerve blocks. If you have carpal tunnel or cubital tunnel, tarsal tunnel, I can block those nerves directly with ultrasound or even fluoroscopy under live X-ray. So it's the safest way to do it, and see if the pain responds to that, or the numbness and tingling goes away. There's pretty much many different types of peripheral neuropathies, and people hurt in different areas. If there's a nerve that can be targeted or that's suspected to cause that pain, I typically try to block it as safely as possible with ultrasound or fluoroscopy.
How long does that last?
That really depends on the patients themselves. Sometimes it lasts from a few days, sometimes it lasts for a few months, but if they do respond to the nerve block itself, and depending on the nerve, sometimes we can go in and we can burn the nerve. The nerve grows back. That's all done under live X-ray. We don't burn motor nerves, so you don't lose motor function. We do a lot of testing before we even burn the nerves.
Or it's probably not the best word.
Well, we can use the word ablation. But I typically do that for arthritis in the neck, all up down the body, and it usually works pretty well. But not for every nerve. Specific nerves I won't do. There's sympathetic nerve blocks. The sympathetic nervous system is involved in your flight or fight response. Let's say you see a bear, you're either going to fight or you're going to run off. Your adrenaline goes up, your epinephrine, norepinephrine goes up, and that's when that's released into around the nerves, that can cause increased pain. And when you've had this pain for so long, this peripheral neuropathy, your body becomes sensitized to it, and it's kind of wound up. and it doesn't stop. The nervous system is continuously going, the sympathetic nervous system is continuously firing off, and that can be a source of pain. I do sympathetic nerve blocks. The sympathetic nerves to your legs lives outside the spine. It's called a lumbar sympathetic nerve, and if it's in your peripheral neuropathy in your arm or your neck or your head, there's a nerve here called a stellate that's outside of the spine and the neck. That can serve as diagnostic and therapeutic. The reason why I say diagnostic is that if I'm able to block that sympathetic nerve and it works, we know that your peripheral neuropathy or your pain is sympathetic mediated coming from that nerve itself. Therapeutic is if it works, we know it works, and that's something that can safely be done over a few weeks to months. Of course, there's side effects with steroids. You have to be careful about how much steroids you give over a period amount of time. So, and of course, I have radiofrequency ablation. Now, if you've responded to the nerve blocks after 1 to 2 times, it may justify going in there and ablating the nerves, or quote-unquote burning the nerves. We burn ablate at a low temperature, typically about 60 degrees. It's not like a scalding hot pan or anything like that. And that will last from 6 months to a year. If it comes back sooner, sometimes we'll try something a little bit different with a higher temperature. And of course, when everything has failed, physical therapy, behavioral health, which they give you techniques, biofeedback, that's failed, medications have failed. If the patient's an appropriate candidate, we do spinal cord stimulators, which, have you guys heard of spinal cord stimulators? That works sometimes, people with peripheral neuropathy, and there's a trial period with that. We put those in an office, and you get to keep it for a week, play with the settings on it, and if it works great, giving at least 50% pain relief, well then we would do a permanent implant, which some people like very much, because if we can treat the pain with either injections or a spinal cord stimulator, you don't have to be reliant on medications and experience the long-term side effects of medications. Any questions so far? Okay. Steroids, some side effects of steroids is you get weight gain, water retention, and you may, if you were to stop the steroids, you end up getting low blood pressure. That's like chronic steroid therapy. People with autoimmune diseases or like rheumatoid arthritis or sometimes are on daily steroid doses, and when they stop it immediately, the body can't compensate for that stop of exogenous steroids, so they end up going into a low steroid level, causing low blood pressure and a host of other problems. I typically like to view it over 3 months. If I do injections on patients when it's time to, and they work, but if we get to a point where it's time to take a break from the injections, I'm pretty honest about it, and it's time to take a few months off before I give more steroids. I have some pictures here of how we do some nerve blocks for carpal tunnel. You can see the a straight line through there. That's typically the needle. That's what I see on ultrasound, directed towards the nerve itself. And you can see all the vasculature, blood vessels, and other nerves to avoid any damage to those. There's one of the tarsal tunnel. And some docs will do it without ultrasound. I prefer to do it with ultrasound because I like to make sure that the medicine gets where it needs to go. And there's no question that it didn't get where it needed to go, and it gets around the nerve, and we know it's there, and if it didn't work, well, I'm not going to repeat that nerve block again because it's a waste of time and money.
Can I ask a question?
Mm-hmm.
Do you find that people come to you more from referrals, or do you require a referral to come to you? Are they exhausted a lot of other stuff before they get to your door?
Sometimes they do. They've gone through all their pain docs, and or it's their first time visiting me. Some people come in without referrals, which is completely fine. It depends. I guess it depends on the insurance if they require a referral from the primary care physician. But I'm happy to see anybody, regardless of who you've seen in the past. And I like to do my own investigation and get a good history and physical and see what's been done by getting notes from the other offices and not repeat things that weren't effective.
And then my second question, one of the things that we've talked about as we've met as a group over the years, that sometimes something might work for you for a while and then not, and then something maybe you tried before it didn't work and now it does. Is that the same case with this, or is this a different situation?
It's you know, if it never worked before, and I'll get the operative notes from the other pain doc who did the injection. Was it done under ultrasound? Was it done under X-ray? Was it done blindly, where they just stuck you where they thought it needed to go? If I feel that it warranted a second try with ultrasound to ensure that the medicine got where it needed, I would try it again. I'm always open to try different things and think outside the box. I do what I can as much as possible doing interventional procedures to treat the pain directly.
What is Sjogren's?
Sjogren's is an autoimmune disease. You know, it can affect your eyes, your heart, your lungs. It's usually associated with some people with rheumatoid arthritis or lupus also have Sjogren's on top of that. It can affect, you know, peripheral neuropathy. You usually don't see Sjogren's or peripheral neuropathy, but I'm not saying it's not possible. It's one of those disease states that you treat symptomatically and try to prevent your own body from attacking your own cells.
Now, could that cause neuropathy also?
Absolutely, it's possible, yeah.
Because I've gone through all the different tests, and I've taken the Lyrica, I've gone down the alphabet with all the different medication, and then the doctor said, don't take anything else for it, it's not helping you. But I had, 1998, I first started having lumbar disc disease, and I've had 5 back surgeries, and my neck enough fusion and enough everything. And the doctor said to the neuropathist I went to, told me that this is what caused, but they also told me that I had Sjogren's, and there's nothing to do about the Sjogren's.
Sjogren's, you probably have to see your rheumatologist. I think one point you do mention that's very important is that if you've had a history of degenerative joint disease or disc disease in your neck or back, that's something you have to rule out too, making sure it's not causing that peripheral neuropathy.
Now, would it cause the neuropathy in my feet?
It may cause like the same sensation as a neuropathy. People who have had back surgery typically can have what they call a failed back syndrome or post-laminectomy syndrome, where the pain radiates in a very specific pattern down into the toes and feet. And that you will have to correlate with a really good physical exam and history.
So there really is nothing to do for that?
For the Sjogren's? Usually not, unfortunately. Yeah. We typically treat symptomatically as best as we can. Any other questions so far?
What about, like, if you have a lot of pain in your feet? I do a lot of swimming because it doesn't put any pressure on my feet. But what about walking? Because I notice when I walk a lot, my feet start burning, I get more pain. Is that really damaging something, or is that just a reaction to putting pressure on the feet?
I wouldn't say it's necessarily damaging. It may be due to the pressure on the feet, more irritation of the firing off of the nerves. I think if it was more damaging to the feet, you'd probably notice some physical exam findings that are there. A lot of it, I think it's just pain being transmitted up through the nerves. Because usually my goal is, that I tell my patients, is to keep you functional and going as best as you can, doing your activities of daily living, spending time with friends and family, and not being trapped by having pain and depression. Yeah. Any other questions so far?
Is it important they never could tell me what was causing the neuropathy in my feet. I've had full range, I had an EMG, I had all this blood work. Is it possible that neuropathy has no cause, like that's just a certain number of cases are like that?
Yes.
It's kind of frustrating when you have something, you don't know where it's coming from.
Yeah, I get a few patients like that in clinic where there's no known cause, there's no physical exam finding that's indicative of what's causing it, there's no imaging, nerve conduction tests, MRI that could explain anything like that. And it does occur. Yeah. Unless there's a cause that no one's been able to find or pinpoint. Yeah. Any other questions before? I have a few pictures of the sympathetic nerve blocks that I use if it's that there's both diagnostic and therapeutic for people who've had chronic peripheral neuropathy. I've done lumbar sympathetic blocks on people with diabetic peripheral neuropathy where their feet are burning, and they'll get more than 50% pain relief for approximately a week, and then we end up ablating those nerves sometimes if it's justified. And it usually works pretty well, and there are people who just don't respond to it, and I typically don't repeat the same procedure if it doesn't work. The second picture here is of the L8. It provides a sympathetic nervous system to your head, your neck, and your arms. This not only treats peripheral neuropathy, but chronic regional pain syndrome, or even headaches that occur. The sympathetic nervous system is involved in many different types of pain. And of course, there's a spinal cord stimulator, which I'm sure people are familiar with. That's implanted in the epidural space. It goes up just like a labor epidural. And we permanently implant it. Everything's under the skin if it works well. And it's a rechargeable battery.
Is it dangerous to take Tylenol every single night?
Not necessarily. Typically, it depends on your medical history. If you have a history of liver failure or cirrhosis, if you stay below I like to stay on the safe side. The old guidelines were if you had a healthy liver, you could take, if you took less than 4 grams a day, it was safe, but I think a lot of physicians now are trending more towards staying below 3 grams per day if you have no liver disease. And if you have a liver disease, they recommend staying below 2 grams per day. Tylenol it's essentially acting drug that works in the brain. It's an alpha agonist. Yeah.
What about Tylenol PM?
Tylenol, that should be fine too. I think they usually add a little diphenhydramine there to get you asleep. This is Benadryl.
If I take that and I wake up in the morning, I still wake up in the middle of the night all the time. When I wake up in the morning, I'm like, oh my God, what did I have to drink last night?
Yeah, I've tried Benadryl or diphenhydramine at night. You usually wake up with kind of a little grogginess, and it lingers throughout the day. Yeah.
You do have to be careful if you're taking Tylenol PM or the other over-the-counter medications. If you're taking them every day or every night over a long period of time, you really need to talk to your doctor about it because it can affect dementia-like symptoms that you might have. So if you're taking it on a daily basis for more than a few weeks, you should probably talk to your doctor about it.
Any other questions? I think it's very important to find someone who takes a really good history on you, does a really good physical exam, and orders the appropriate labs. They have to be justified. I get a lot of patients that come in who've had injections that don't work. An epidural steroid injection does not work. That's not the end-all, be-all that works for everything. You have to do the right diagnosis based off the history and physical exam and the right injection to get the best chance of it providing pain relief. Because I've gotten patients from other practices who say, oh yes, I got this injection. It didn't work. Well, it may have not been the right injection for the right diagnosis. That's why it doesn't work. So you have to be cognizant about that.